Good afternoon, and thank you for joining us today. My name is Karen Sampson Hoffman, and I'd like to welcome you to this special presentation, Health and Life Expectancy in ADHD. Treatment Matters More Than You Think. Today we are featuring Dr. Russell Barkley. Today's webcast is a special presentation of CHAD and its National Resource Center on ADHD. The NRC is funded by the U.S. Centers for Disease Control and Prevention and provides reliable, science-based information about current medical research and ADHD management. CHAD is the nation's largest family-based organization for people affected by ADHD. During this webinar, we would love to hear from you. You can ask questions or share comments when the Q&A comments box is opened after the presentation. Dr. Barkley will answer a few questions when the presentation is complete. Also, there is a box labeled Resources, where you can download the slides for today's presentation. If we don't get to your question today, we have health information specialists available Monday through Friday from 1 to 5 p.m. Eastern Time. You can reach them at 1-800-233-4050. I'm very pleased to introduce Dr. Russell Barkley. Dr. Barkley is an internationally recognized authority on ADHD in children and adults. He has dedicated his career to widely sharing science-based information about ADHD. Dr. Barkley is a clinical professor of psychiatry at the Virginia Treatment Center for Children and Virginia Commonwealth University Medical Center in Richmond, Virginia. Dr. Barkley, thank you very much for being with us today.
It's my pleasure. Thanks so much, Robin. I appreciate your help today. Are you able to hear me all right?
I can hear you well. I believe our audience can also hear you.
Great. Just wanted to be sure that the sound is appropriate. So before we begin, I first of all want to thank you and especially the CHAD organization for promoting this webinar as well as this topic more generally through media presentations and press releases and so on, in addition to the presentation I'm going to do for you today. So thank you. And to begin then, Robin, let's start with this slide. I just want people to know that there are lots of resources besides those offered by CHAD that are on the internet, and I have 30 hours of lectures posted to the ADHDlectures.com website that are available for free viewing, as well as other courses on the internet for professionals wishing to have continuing education credits toward their licensing. It's also appropriate for presenters like myself to show you our financial disclosure statement for the previous year so that participants are able to evaluate whether or not there might be any conflict of interest between these sources of support as well as the content of the program. So here is where I've spoken during the previous year, as well as where I receive royalties and fees for consulting and speaking on behalf of various industries. Today's presentation is going to be about the health outcomes of children and adults with ADHD, and we're going to consider whether or not these health outcomes over the course of their lifetime, if they remain untreated, might have an adverse impact on the life expectancy of those with ADHD. We've known for a long time that individuals with ADHD are at risk for a variety of difficulties, and these stem from the two primary symptom domains that characterize ADHD. For instance, clinical researchers know that ADHD involves delays and deficits in two dimensions of neuropsychological development that comprise this neurodevelopmental disability. These symptoms or deficits lie in the realm, first of all, of poor impulse control and behavioral disinhibition, otherwise known as executive inhibition, which gives rise not only to the hyperactivity, but to a variety of forms of inhibitory problems. These can take the form of difficulties with inhibiting motor responses, which is where the hyperactivity, restlessness, and fidgeting comes from, but also difficulties with verbal inhibition, such as excessive talking, interrupting, and other items that are noted in the DSM-5 diagnostic criteria. But more than that, we also see that there are difficulties with impulsive cognitive actions, so that the individual has difficulty suppressing task-irrelevant thoughts, makes rapid decisions, and fails to contemplate the outcomes of their actions before they engage in those actions. In addition, there's a motivational inhibitory problem associated with ADHD in which the individual opts to go after, in an impulsive way, the more immediate consequences in a situation rather than to defer their gratification and pursue longer term, larger, and more socially important consequences. And so we see a lot of problems with this impairment in delay of gratification. Researchers often refer to this as discounting the value of the delayed consequence. No matter, it simply means that there's a preference for immediate small rewards over delayed larger rewards. Unmentioned in the DSM-5 in the criteria is that there's also an emotional impulsivity associated with ADHD. The individual has difficulty suppressing emotional reactions to events. These reactions are rational. They're not irrational as we would see in a mood disorder like bipolar disorder. But they are impulsive, and they are stronger and more extreme than they would be because the individual has trouble engaging in the top-down executive or self-regulation of these primary emotional reactions to events. And this often leads to significant problems socially and in the workplace environment. Now, the restlessness declines over time such that by adulthood it is no longer a significant diagnostic set of symptoms. But the impulsiveness, as we've identified it here, certainly persists over time through adolescence and into adulthood. Now, besides these difficulties with impulsivity, there are also the well-noted problems with sustained attention, after which the disorder is named. But it is best that we think of these as executive functions rather than as simply problems with attention, because that conveys the more pervasive problem that people with ADHD have in their cognitive functioning. So we see not only that they have difficulties concentrating, but they manifest poor persistence over time toward goals, and they can't sustain their attention toward these future activities as well as other individuals are able to do. So it's more precise to say that ADHD is not really an attention problem, it's an attention to the future problem. That is, getting ready for what comes ahead, what lies next, pursuing one's goals, and sustaining one's actions toward those goals until the goal is accomplished. Now, in order to do that, one has to be able to resist distractions along the way, and individuals with ADHD, as we know, are highly distractible. That is, they show an impaired resistance to responding to goal irrelevant, external, or otherwise distracting events, some of which may simply be other competing internal thoughts or events that they're experiencing. So along with the poor persistence, there's a high level of distractibility. In addition, once distracted, people with ADHD find it very difficult to re-engage their goals uh, as other people are able to do. And so they wind up skipping from one incompleted activity to another once distraction occurs. This difficulty with re-engaging the goal, holding the goal in mind, and returning to the goal until it's completed is actually a problem with what we call working memory. Working memory is a special kind of memory that I think of as remembering what we're doing. People with ADHD are not forgetful of information. They're forgetful of what they're supposed to be doing at a particular point in time, particularly if they've been distracted away from their goal. And so we see substantial difficulties with this ability to hold information in mind that's related to goal-directed behavior. And that also includes a capacity for self-monitoring during the goal performance. And so we see a much reduced self-awareness in people with ADHD. So the last two slides have shown you how clinical researchers like myself think of ADHD beyond just the 18 symptoms that we see in the DSM-5 diagnostic criteria. Now, many studies exist, more than 50,000 in fact, to show that ADHD is associated with a variety of impairments in childhood. And we've known this going back for at least 50 years And indeed, the more than 225 years that ADHD has been recognized as a disorder in the medical literature. For instance, we know that children with ADHD are often delayed in their motor coordination and development. A significant number of them may indeed have speech delays, particularly with what we call the executive or pragmatic aspects of speech, which is using speech to interact effectively with others, to solve problems, and to pursue their goals. There's also a substantial delay in the development of independence or adaptive functioning, such as what we would see in self-care routines. And so even in the beginning, during the preschool or early childhood years, we're beginning to see some delays in development in critical areas that are related to self-regulation. Eventually, as the symptoms of ADHD emerge or become more severe, we begin to see problems with family conflict. There's a lot of difficulties in parent-child interactions with getting the child to do what they should be doing on their own for their age. And this leads to a lot of yelling, directions, commands, instructions being given by parents, as well as resistance by the child, sometimes with increased oppositional and defiant behavior, arguing, all of which leads to a great deal of turmoil within the family and a lot of stress on the part of the parents, often 24 hours a day, 7 days a week across most domains of functioning. Beyond that, as the child moves into the school environment, we begin to see difficulties with poor academic achievement. In at least half of the children, we may see frank learning disabilities emerging, such as reading disorders, writing disorders, difficulties with speech and language, sometimes difficulties with mathematics. But in general, there's at least a 50% risk for learning disabilities in children. Their behavioral difficulties often lead to school maladjustment with regard to behavior problems in the classroom, as well as difficulties in peer relationships. And then, of course, as they move outside the home into the community, these peer relationship problems are often seen with other children in the community, such as at the bus stop or in other community settings. Up to 50% of ADHD children may have difficulties with peer problems, such that they have no close friends by the end of second or third grade. And if the child with ADHD has oppositional defiant disorder or conduct disorder, this figure rises to over 70% of them have difficulties with forming close and sustained peer relationships with others. Over time, we begin to see comorbidity with other psychiatric disorders beginning to take place. The most common is oppositional defiant disorder, where we see at least two-thirds to three-quarters or more of ADHD children having difficulties with defiance, with noncompliance, with aggression, with difficulties following through and obeying parental commands, this being the most common comorbid disorder that arises within 2 years of the onset of ADHD. This often leads to the development of conduct disorder in about 25 to 35% or more of ADHD children, a pattern of antisocial behavior, lying, stealing, fighting, and aggression in a substantial minority of these children. About 20% of ADHD children may qualify for mild to moderate autistic spectrum disorder, and at least 20 to 25% may also develop anxiety disorders. By adolescence, we also begin to see the development of low self-esteem, demoralization, or even frank major depressive disorder in a subset of ADHD children, particularly if they have a family history of major depression. A very small subset might go on to develop bipolar disorder, but here again, this is often only in those children who carry a family genetic history of risk for bipolar disorder. By movement into adolescence, antisocial behavior starts to become more commonplace in a subset of children, not in the not in the majority, but in a minority of children, where again we begin to see difficulties with antisocial behavior in the community, again such as lying, stealing, fighting, uh, and aggression against other individuals. So by adolescence, we've seen a large number of children with ADHD experiencing a variety of risks in various domains of major life activities. Moving into adolescence and early adulthood, we see additional difficulties besides the ones I've already mentioned. Teenagers with ADHD have an increased risk for tobacco use, and as they get older, for marijuana and alcohol use. And once they begin experimenting with these substances, at least 25% of them may move on to have a legitimate substance use or dependence disorder. As they become sexually active, we see that they do so earlier than other teenagers and in a very impulsive and risk-taking way. This may lead them to not use contraception when they should be, to engage in sexual intercourse earlier than others, or in just a general pattern of risky sexual behavior. And this leads to about a 30 to 35% risk of a teenage pregnancy before they reach 19 years of age. And at least 15 to 20% of them may develop a sexually transmitted disease by this age. So risky sexual behavior becomes an increasing risk over time for the teenager with ADHD. Of course, by age 16 or later, as they begin to move into the domain of driving, we see that this is also an area of risk for them, where they have at least 3 to 4 times the crashes that other people have as they begin their driving careers. They have 4 to 5 times the speeding tickets, an increased risk of all traffic citations over time, and a growing risk, particularly in that subset who has a substance use disorder, of driving under the influence. So driving is a major area of risk of impairment for the teenager and young adult with ADHD. Beyond these, we also see as they move into young adulthood and begin to enter the workforce, problems with occupational functioning, advancing as quickly as other people up the occupational ladder, beginning to develop financial difficulties because of their impulsivity and risk taking, so that they have problems with managing credit, repaying loans, paying their bills, managing their money, and so forth. They change jobs more often as well and have at least a 3 to 7 times more likelihood of being fired from employment than other people, particularly due to their emotional outbursts in the workplace. As they begin to develop long-term, sustained, intimate relationships with others, such as in dating, cohabiting, and even in marriage, we see that there may be heightened areas of conflict, greater distress, lower levels of marital satisfaction, and in a small subset of people with ADHD, a growing risk for intimate partner violence against their partner when they are frustrated or involved with conflict behavior with their partner. For those who go on to have children, individuals with ADHD often report a greater impairment in their parenting behavior, less able to monitor their children as well as others, often finding that they're more emotional in their interactions with other children and displaying less positive behavior toward their children. Of course, this would be expected due to the parent's own ADHD symptoms. So all of this is to say that for many decades now, we have recognized that, excuse me, ADHD individuals carry a lot of risks in a variety of domains of major life activities, leading us to conclude that ADHD by adulthood is one of the most impairing disorders that people can have and be treated on an outpatient basis. Now, what about their health outcomes? Well, over the past 10 to 20 years, researchers have begun to document that the impairments with ADHD are not just in education, occupation, family, and social functioning, but are in areas of health and wellness. For instance, we know that children and adults with ADHD carry a much higher risk for traumatic brain injuries. Again, this is secondary to their greater risk taking, and that this is seen not only in sports, but also in their driving and in other areas such as motorsports. And once they may experience a traumatic brain injury, this may feed back to worsen their ADHD symptoms over time. And this may take as long as 6 to 9 months after the closed head trauma or traumatic brain injury. People with ADHD are also at risk for repeated head injuries, not just single head injuries. We also have known for many years that children and adults with ADHD are at risk for all types of accidental injuries, including broken bones, lacerations, closed head trauma, burns, accidental poisonings, and so on. So they're a very high risk group. In childhood, this alone doubles the likelihood of early mortality before reaching adolescence. And by adulthood, the risk of dying by age 40 is nearly 5 times greater than that of other individuals of their age, primarily due to accidental injury, but also due to a growing risk for suicide attempts and completions by late adolescence and moving into early adulthood. The 25 to 40% of ADHD children who by adulthood have developed antisocial personality disorder are ones who may also have a risk for violence against others and therefore are both the perpetrator and sometimes the victim of their reactive aggression in interactions with other people. And this can also be an area which influences, of course, their medical health and well-being. All of this can lead to a much greater likelihood, along with the accidental injuries, of visitations to emergency rooms because of these injuries. We know that children with ADHD carry a risk for earlier childbearing, as I've said, teenage pregnancies, and sexually transmitted disease, and this increases their likelihood as well of developing other medical problems in their adolescence and adulthood. People with ADHD by adulthood often tell us that they have poor physical health and well-being. They tell us that they have more vague bodily complaints, headaches, and so on, sleeping difficulties, and this occurs to a much greater extent in people with ADHD than in others of the same age, and it's especially common in those who may have difficulties with anxiety and depression. There's a small group of studies that suggests there may be a risk for fibromyalgia, as well as for, just as I said, general difficulties with bodily complaints and complaints of pain. This is especially more likely to occur in females with ADHD, whereas you see here, at least 30% of them may wind up with a diagnosis of fibromyalgia. Migraines have been linked to ADHD most recently, and the link appears to be one of a shared genetic risk, such that people with ADHD have a genetic predisposition to an increased risk for migraine headaches. Besides that, we see that in their health and lifestyle, people with ADHD opt for a more Western diet with using fast foods, high carbohydrates, high sugar-based substances, a greater use of sugar fluids, and just generally a diet that is much higher in carbohydrates. And as we know, these complex carbohydrates bring with them increased exposure to sugar, and this, of course, leads to not only difficulties with dental hygiene, having more dental plaque, dental caries, but also the greater risk of accidental injuries applies to their dental health, where we see a growing risk for dental trauma in these individuals. And of course, the Western diet is more likely to lead to a greater risk for obesity, such that by adolescence and adulthood, they have at least 3 times the rate of obesity compared to other individuals. In my own follow-up study, nearly 40% of the children we followed to age 27 qualified as obese, given their body mass indexes, compared to less than 20% of our control group. So again, at least a doubling, if not tripling, of the risk of obesity by adulthood. Several studies have now documented that there's a growing risk for type 2 diabetes in teens, and as you see here, especially by adulthood, where they have at least 3 times the risk for developing this form of diabetes. And of course, that makes infinite sense when we look at the fact that they may be more obese, that they may be consuming much more sugar in their diet than others, both of which increases the risk for this form of diabetes. Recent research also shows that ADHD shares underlying genetic risk with diabetes as well. So it's not just their environment, their lifestyle, their diet, and their physical weight, but also their genetics of ADHD that might be pushing them toward this greater risk for diabetes. Females are now known to have a greater risk for eating pathology, particularly for impulsive eating, binge eating, or even to the more severe form of bulimia, which is the binge purge form of eating disorder. All of this is linked to their greater propensity for impulsivity, particularly around food, and may be further compounded by their peer rejection, their growing risk for demoralization and depression, which leads to sort of impulsive eating as well. And then if they are exposed to harsh parenting, we see an increase in impulsive eating in response to this kind of family environment in those with ADHD, as you see on this slide. Now, as I mentioned earlier, another health consequence of ADHD is the greater experimentation with tobacco. We know that people with ADHD are more likely to try tobacco. If they try it, they're more likely to increase their use of tobacco such that they smoke more than even other tobacco users. And one explanation for this is that nicotine is known to treat ADHD. And so people with ADHD might find that smoking helps to manage their symptoms. But of course, they're using one of the most addictive substances to try to do so when they self-medicate with tobacco. And so that's the downside to trying to manage your ADHD with tobacco. Over time, there's a growing risk for excessive use of marijuana and alcohol as well, so that by adulthood, these substances become more problematic in addition to nicotine. Now, if the individual has conduct disorder, then that is going to predispose them to also using other hard drugs such as methamphetamine, prescription drugs, cocaine, the opioids, and so on. But ADHD alone, even in the absence of conduct problems, creates a growing risk for tobacco, marijuana, and alcohol use to excess. Now, of course, if you were to look at this pattern of behavior that you see here on this slide, it doesn't take a genius to infer that if this pattern continues over time, the individual is going to be at a growing risk for cancer. We know that excessive alcohol use and tobacco use both are risk factors for cancer in later life, not just for lung cancer, but other forms of cancer as well. And of course, it's not just cancer that we're worried about, but these other factors that I've mentioned would predispose toward cardiovascular disease and a growing risk for coronary heart disease events such as heart attack and stroke. In my own follow-up study, by age 27, we had documented a lower level of high-density lipids and the cholesterol profiles of our children with ADHD by young adulthood, a worse ratio of their HDL to their total cholesterol, a growing risk for atherosclerotic plaque in their arteries, and all of this, of course, would therefore argue for a greater risk for coronary heart disease and events over the next 5 to 10 years of the follow-up of these individuals. So again, this is not speculative. The health and wellness problems we're seeing in people with ADHD are going to place them at risk over time for coronary heart disease if we don't begin to take these problems more seriously. Recently, there have been a few studies that have shown a small but increased risk for dementia later in life during the elderly years of people with ADHD if they wind up living that long. And while the risk is still small, about 5.5% or so, that risk is nearly 3 times greater than we would see in other individuals of the same age. There is at least a 2 to 2.5% risk for other diseases of the basal ganglia of the brain, specifically for Parkinson's disease and diseases of the cerebellum. These studies, of which there are only about 2 or 3 at the moment, suggest that this is even worse in people who have taken stimulants over time. But please don't think that this is as a result of the stimulant treatment. We know that people who are given stimulants for ADHD have a much worse form of ADHD than those who are not recommended for stimulant medication. And so this relationship with basal ganglia disorders could simply reflect a more severe form of ADHD and may have nothing to do with treatment with medication. More recent studies looking at genome-wide scans of the entire human genome show that there is a shared genetic risk between ADHD and an increasing risk for a variety of health and lifestyle problems, such as I mentioned, diabetes, obesity, sleeping difficulties, risk for smoking. So it's not just the environment and lifestyle that is causing these problems, but again, an underlying shared genetic risk between ADHD and these other problems. So you can see why, starting a year ago, my colleagues and I, who have helped me with my Milwaukee longitudinal study, specifically Dr. Mary Ellen Fisher out in Milwaukee, Wisconsin, began to entertain the possibility that with everything we were seeing in the life course of our children, excuse me, by adulthood, that we were likely going to see some impact on mortality and on life expectancy. Excuse me for a moment. So we started to look at the data in our study, understand that we had done complete physical exams of our children at their adult follow-up. So we had a lot of data that we could use to look at life expectancy. And one of the reasons we suspected that there was an impact on life expectancy, as I said, is that there was a growing risk for death by midlife due to accidental injury and to suicide. And so that alone suggested that there were going to be problems with longevity in the population. Our study was also the first to document that by adolescence and early adulthood, there was always also a growing risk for suicide attempts, unfortunately, and suicide completions among our young adults with ADHD, particularly if they had comorbid depression. But we also found that there was other evidence in the literature for this risk for mortality from several studies published just over the last 6 years. As you see on this slide here, as I mentioned already, ADHD children are at least twice as likely to die before reaching adolescence and adulthood because of accidental injury and suicide. And ADHD adults are more likely by at least 4 to 5 times to die by midlife. So we were on good footing here in wanting to go back into our data set and see what the longevity would be of our ADHD children by young adulthood. So just like an insurance company would do if you applied for life insurance, we went back and scoured the histories, the medical histories of our children, their lifestyle, as well as did complete physical exams and laboratory studies of blood, urine, and so on with our children at adulthood so that we might take a look at what a life insurance company would do, and that is what would be your predicted life expectancy given your current lifestyle and medical and health risks. So here are my colleagues in this study, and this is the study we're going to talk about, which was just published last week in the Journal of Attention Disorders. And if you're not familiar with our Milwaukee study, we have followed 158 children well diagnosed with ADHD combined type, or what was called hyperactive child syndrome, back in the late 1970s when we started this study. Along with these children, we have recruited 81 control children from the same schools and neighborhoods so that we could match them not only on their age and sex, but also on their family's socioeconomic status. We followed these children again by adolescence, age 15, where we had a very high rate of participation, and we've seen them every 5 years since up to age 27, where at least 85% of the ADHD cases and 93% of the control cases came back for our evaluation. So we have a very high retention rate of our children returning for our evaluations. At young adulthood, we subdivided our ADHD children into those whose ADHD had persisted to adulthood, that is, they still qualified for a diagnosis of ADHD. And so we're going to call this the H plus ADHD group, that is hyperactive as children and ADHD at adulthood. We then also had a group of children whose ADHD had not persisted to age 27, and we call them the H minus ADHD group. Now, understand some of these children actually had completely recovered from their disorder. Conservatively estimated, it was about 14% of our children could no longer be diagnosed as ADHD, and indeed were no different from our control group in the number of impairments and symptoms of ADHD that they experienced at the young adult follow-up. So about 1 in 6 to 1 in 7 children in our study had actually completely recovered from their ADHD, but the remainder had not. And as I've said, at least half of them retained full ADHD to adulthood, and the remainder remained highly symptomatic and impaired, even if they didn't qualify for a full diagnosis in adulthood. So let's understand that the group whose ADHD has not persisted to adulthood, the majority of them still have significant symptoms of the disorder and are still impaired by their disorder in reaching adulthood. And we've reported a large number of studies of these children over the past 25 to 30 years that we've been engaged in this follow-up study. But here I want to talk about the study we published last week. And this was a study looking at life expectancy. We were fortunate last year to have had made available to us online a calculator that is used to calculate life expectancy. And this was freely available. It's not a commercial calculator, as you would see if you went to the website for a life insurance company, where you might enter a couple of variables such as your age and sex and a few other questions that you have to answer, and they'll give you a rough estimation of what your life expectancy might currently be. This is a much more sophisticated calculator, as might be used by an insurance company, and it was made available to us by the Goldenson Center for Actuarial Research at the University of Connecticut. And this mathematical algorithm, or calculator as we call it, uses 14 variables. And we were fortunate to have all 14 variables in our data set. And so we went back into our data and converted our data into what was needed to compute this calculator for each and every child in our study who was available at the follow-up point. And here you see some of the variables that are used to compute one's life expectancy. By the way, life expectancy is simply how many years can we expect you to have left at your current age if your current lifestyle with regard to all of these factors continues unchanged. Now, of course, if you change any of these variables, then it changes your life expectancy. But to quote Charles Dickens in a way, or at least to amend his quote from A Christmas Carol, if the shadows of what currently is are unchanged, then we can expect that this is what will happen over time. And so if the shadows of these variables remain persistent, then the life expectancy is what we computed in this study. So we entered their sex, their current age. They had a mean age of 27. The range was around 24 to 32 years of age. We had their height, we had their weight, we had their income from their current occupation, whether or not they were diabetic, which very few children were by age 27. We had their current health status as they had rated it on a rating scale of at least 59 different medical complaints. We had their current nutrition. We had interviewed them about their nutritional status, and we categorized this as good, excellent, fair, or poor. We had the number of times they exercised weekly as they self-reported it to us. Usually this was in the area of about 1 to 3 times per week, but many individuals did not exercise at all in the ADHD group. We also had interviewed them about the quality of their sleep and how many hours of sleep they got per night. And we categorize this into the three categories you see here as to whether they had at least 8 hours or more a night, 5 to 8 hours, or less than 5 hours. Now, education is important in calculating someone's life expectancy, and so we entered that as well. If you get a high school education, it may impact your life expectancy. And if you get education beyond high school, then it can add at least 11 months to your life expectancy beyond the life expectancy of a high school graduate. So for every year past high school, you can add another 11 months to your life expectancy. And so we did so in our calculator. Driving is also a variable in the calculator, and risky driving in particular. And so we classified our ADHD and control children based upon how many license suspensions and expulsions they have in their driving career. And of course, this was 0, 1, 2, or more. And of course, ADHD individuals had more license revocations because of risky driving. We, of course, entered their current smoking status. Did they smoke or not currently? And in addition to that, we also added into the calculator whether they smoked 20 cigarettes or more per day, because that alone will or decrease your life expectancy, excuse me. So it'll decrease your life expectancy by 2.5 years beyond the 4 years or more that smoking alone will do. And then, of course, alcohol use enters our calculator. So we took all of these variables out of our data set and put them into the calculator. And what did we get? And you see the results initially here. What you're seeing here is the comparison of children who were ADHD combined type in childhood, or hyperactive child syndrome. Didn't matter whether they outgrew it or not. This is simply whether they had a diagnosis of the disorder in childhood versus the control group. And we broke our results down into three types. On the left, you see the number of healthy years they could be expected to have from age 27 onward. In the middle is the number of unhealthy years they might have, in other words, the number of years of sickness. And then on the right, the total, which is their total life expectancy. What you see here is that if you were diagnosed with ADHD in childhood alone, doesn't matter whether it persists or not, your life expectancy is going to be at least 8 to 9 years less than that of someone who grew up without ADHD. And by the way, treatment does not matter in this study because most of the children in this study got treatment as children, but by adolescence, 3/4 of them were no longer in treatment, and by adulthood, 90 to 95% of them were no longer being treated. So they're largely a childhood-only treated group of individuals. And that explains why treatment in this study had no effect on any domain of outcome, not just life expectancy, but any other domain. What that means is that if all you do is manage ADHD in childhood and you don't pay attention to treatment in adolescence or adulthood, then there will be no effect on the child's life course by adulthood. It's a very sobering finding. What we see next is where we went and subdivided our children into whether or not their ADHD had persisted to adulthood. So now you see 3 bars. Let's take a look at the left-hand side. Here we see number of healthy years of life expectancy left, and the dark bar on the left is those who had ADHD and it persisted to age 27 to the follow-up. And what you're looking at here is about a 12.5-year reduction in life expectancy. If their ADHD had not persisted to adulthood, their life expectancy was about 7.5 years less than what you see in the light bar, which is the control group. Over on the right-hand side, you'll see their total life expectancy broken down by whether ADHD had persisted or not. And here you will see that it's about nearly 11.1 years of reduced life expectancy in those whose ADHD had persisted. In the group whose ADHD had not persisted, it's about, as you see here, 6.5 year reduction in life. So overall, it's persistent ADHD over time that really reduces life expectancy. But even growing up with ADHD where it doesn't fully persist to adulthood, there is still a detrimental effect going forward on your life expectancy. So again, we were not surprised, although I have to say we were a little shocked at the magnitude of the results. We expected at least some effect on life expectancy, given what we knew about the health status of our children. But this is a very large magnitude of life expectancy reduction. And in case you don't believe that, let me put this in context. ADHD is twice as bad in its effects on life expectancy as the top four killers in the United States. That is, the top four causes of reduced life expectancy, those being obesity, smoking, alcohol use, and lack of exercise. And of course, diabetes, but very few of our children had diabetes. So ADHD is worse than any one of those major killers and is worse than all of them combined in this study. So I hope that makes you realize just how serious a public health problem ADHD actually is. Understand that our government and our insurance companies and other health maintenance organizations spend billions of dollars a year trying to convince the population to reduce these risks for smoking, alcohol, weight loss, diet, sleep, exercise, and so on. But they don't spend anything with regard to trying to reduce the public health consequences of ADHD with regard to health and life expectancy. And yet, ADHD is worse than all of the conditions we're all so worried about, particularly in the month of January, since we're all making New Year's resolutions with regard toward all of these lifestyle and wellness factors. So you can see why a year ago when I discovered these results and presented them in a scientific meeting, many of my clinical scientific colleagues and I were quite, I think, surprised and shocked by the results, because these are substantial figures in the area of research on life expectancy in the area of public health research. Now, why? Why are these children showing such a marked reduction in life expectancy? Well, we went back in and we compared our ADHD groups on all 14 of those lifestyle, demographic, health, and medical risk factors in the calculator. And here's what explains the reduction in life expectancy. Children with ADHD, of course, have less education. They may earn less income by adulthood on average. They're using alcohol more. They're more likely to smoke. They smoke more when they do smoke than other individuals. They report much less, much poorer health overall than other people do. They get less sleep than other people do. Indeed, 40% of adults with ADHD have disrupted sleep or a frank sleep disorder. And of course, they engage in more risky driving and therefore have a greater likelihood of license suspensions and revocations. So these were the factors we discovered that were contributing to reduce life expectancy. So if we were to come up with intervention programs for people with ADHD, we would want to focus specifically on these things, in addition, of course, to taking a look at all of the other 14 variables that went into computing life expectancy. But especially, we would want to target these: smoking, alcohol, exercise, education, and driving, among other things, as well as sleep. Now, here's something else we did that might surprise people. We know that there are second order or background factors that predispose people to behave in this way, one of which, of course, is ADHD. Why do people smoke more? It's not just random. Not everybody smokes. Why do people have sleeping difficulties? Why don't they exercise? Well, the risk for those problems are not random. Certain people with certain personalities and certain ADHD symptoms are more likely to engage in these adverse health and wellness behaviors. So we decided to take a look at background factors. And we, of course, had already shown that ADHD symptoms were among them. But we also knew from having looked in the area of public health that one of the biggest risk factors that reduces your life expectancy is the personality trait of conscientiousness. Conscientiousness refers to how impulsive are you, or more likely, how likely are you to inhibit your initial impulsive reactions and stop and contemplate the consequences of what you're about to do. In other words, how likely are you to think about what you do, to use your conscience in your daily ongoing behavior? And although we didn't have a measure of the personality trait specifically, we did have a rating scale of behavioral inhibition in our study as part of our executive function rating scale. And so we took a look at the degree to which impulsiveness was driving the reduction in life expectancy. We also looked at intelligence, at other comorbid personality and psychiatric problems, such as anxiety, depression, interpersonal hostility, aggression, and so on. And we looked at certain cognitive traits, such as working memory, planning, problem solving, and so on. Could we show whether any of these things were predisposing our patients, our children, toward these lifestyle problems, these first order factors that reduce their life expectancy? And you see the results here. 31% of the variation in life expectancy is due to a single trait, impulsiveness. We replicated the research on conscientiousness because behavioral disinhibition is the inverse of conscientiousness. So here we see that we only need to know one thing about you in order to predict a marked reduction in your life expectancy. How disinhibited is the individual? And we can pick up a little bit of additional prediction from your IQ, how hostile you are, and working memory. But even those three added only another 9% to our prediction of life expectancy. It really was conscientiousness and disinhibition that explain the majority of variation in life expectancy. And of course, why is the disinhibition so high? Because of ADHD, of course. Now, just as an aside, very quickly, and I know we're running out of time here, we also had genotyped our children in the study on 3 different dopamine genes, and we were able to go back and look at whether or not differences in these 3 genes that everybody in the study had, but how different were these genes in them? Not everybody gets the same copy of these genes. Did these genes contribute in any way toward life expectancy beyond just having ADHD? And the answer is yes. 2 of the genes added additional reductions in life expectancy, and they were the dopamine transporter gene, which is DAT1, and the dopamine beta hydroxylase gene, which is DBH-TAC1. These genes reduced life expectancy by as much as 2 to 5 years in addition to having ADHD. And by the way, that paper was just published yesterday afternoon in the American Journal of Molecular Genetics, Psychiatric Disorders Journal. So if you had ADHD and you also had copies of those genes that were problem copies, you might see up to a 20-year reduction in your life expectancy on average. Pretty striking indeed. Now, there are some limitations in the methods of our study. They are here. Time doesn't permit me to go through them, nor I think are most listeners interested in them, but understand that they are explained in the published study in the Journal of attention disorders and in our other studies. Now, let's understand something. All of the risk factors that we found in our study that were predisposing our ADHD children to reduced life expectancy, all of them can be changed. So while our results are sobering and certainly need to be taken very, very seriously, they are changeable. There is hope. What our study suggests is that there is marked room for improving the health, the wellness, and hence the life expectancy of people with ADHD if we will just understand the risks that ADHD predisposes for life expectancy. Every single one of these things could be changed next week if we simply put our minds to it, paid attention to it, helped children and families and adults with ADHD to concentrate more of their effort and resources on reducing these risk factors. So let's understand there's a lot of room for improvement here. There's an awful lot that we can do. It suggests that families and adults with ADHD, families of children with ADHD, should not overlook these risk factors where they pay too much attention to education, peer relationships, and family functioning. We need to broaden the lens of our focus here to include health, lifestyle, and wellness factors, and not just the traditional domains that we focus on when we try to help people with ADHD. We can change these things, we can improve their lives, their lifestyles, their wellness, and their quality of life in addition to extending their life expectancy. But I also want to add a cautionary note here, and that is that all of these factors, to some extent, are related to the background trait we discovered, which is conscientiousness, inhibition. In other words, ADHD. What this means is that if you were to focus only on, say, losing weight, improving nutrition, exercising more, people with ADHD might well fail at those behavioral change activities. And they would fail because they haven't been treated for their ADHD and particularly for their disinhibition. And if we don't treat the background factor, if we don't pull back the curtain and look at their ADHD and what it's doing to predispose them toward these negative adverse health and lifestyle factors, then they're not going to change. And they'll fail, as they often do. So we have to do something else besides target the lifestyle factors. We have to target the ADHD and specifically the dimension of behavioral inhibition. The dimension of attention gets enough. It certainly predisposes to the academic problems and other difficulties, but it is not a predisposing factor to their lifestyle and their life expectancy. It's the inhibitory dimension, the much undervalued and underweighted dimension of ADHD that poses all of these risks. So as we broaden the lens and look at health, wellness, and lifestyle factors, we need to make sure we look at ADHD again, particularly in individuals who have not yet been identified and diagnosed. So if we are clinicians who work in primary care and we see people who are overweight, have poor nutrition, don't exercise, have elevated cholesterol, high blood pressure, sleeping difficulties, substance use problems like smoking, and we try to change them, and they don't change, clinicians need to re-screen them for the likelihood that they probably have ADHD. And it's their ADHD that is predisposing not only to the lifestyle problems, but to the failure in the self-change programs the clinician is trying to get them to do. So in conclusion, we know that ADHD is a disorder of self-regulation and executive functioning. that these problems with self-regulation predispose to numerous impairments in major life activities, and that growing research in the past 20 years, and specifically the past 5, has shown that ADHD is predisposing toward adverse health and lifestyle problems, and not just education, social, and family problems and occupational problems as well. And that these lifestyle and health problems can negatively impact their life expectancy more than any other lifestyle factors we are currently concerned about today in the United States. As a result, we know that people with ADHD are prone to earlier mortality than are other individuals, not just because of the accidental injuries and risk of suicide that are now well documented, but because of their low conscientiousness, high impulsivity, and propensity to engage in virtually every lifestyle problem that we know contributes to a reduction in life expectancy. What does this mean? ADHD is not just a mental health problem or an educational problem. It's a public health problem. Indeed, one of the major public health problems because it is worse than all of the other public health problems seen individually, and most of them even in combination that we worry about today. This means, number one, families with ADHD children and adults with ADHD need to take seriously the fact that their disorder is predisposing them to major lifestyle, health, wellness, and life expectancy problems. Second, clinicians who work with these individuals with ADHD, psychologists, psychiatrists, behavioral neurologists, ADHD coaches, need to understand these risks and broaden the focus of their evaluations and their interventions now to include health, medical status, wellness, and lifestyle beyond the usual targets of our assessments of symptoms, education, social functioning, and so on. Third, we need to educate primary care physicians about the role that ADHD plays in predisposing people to the lifestyle and health factors that primary care clinicians treat every day: obesity, smoking, alcohol, sleep, nutrition, exercise, and so on. Primary care clinicians do not understand that ADHD is a major risk factor behind the problems they're already treating. Therefore, if they are seeing people with these risk factors, and those people are failing to change their lifestyle and wellness routines that the primary care clinician is trying to help them with, then that primary care clinician needs to pull back that curtain, rescreen that patient for the possibility, the high probability, that they have ADHD, and that that is what is accounting for the failure in self-improvement, and not simply write it off to the fact that the patient isn't motivated, doesn't care, or some other moral failing or choice that the patient may have. It's quite likely they have ADHD. And if they don't treat the ADHD first, then their patients are not going to succeed in these health and wellness improvement activities. Finally, I think we have to work with government public policy and other agencies and insurance companies and others in the public sector who focus on health and wellness to help change our policies with regard to dealing with ADHD as a public health disorder and making available to people with ADHD the resources that they may need in order to address these broader health, wellness, and lifestyle factors. After all, ADHD is among the most common disorders we see in outpatient psychiatric and psychological clinics. It is one of the most impairing disorders that we see. It is now recognized as a substantial public health menace in the population, and yet it is one of the most treatable psychiatric disorders we know of with regard to the number of treatments we have, the success those programs have, the degree to which those treatments can improve our patients. The problem we have right now is not that we don't have treatments. We have under recognition of ADHD in the population, particularly among adults, and we have limited access to care, particularly multidisciplinary care of patients with ADHD. So I hope you will join me in advocating for ADHD as a public health problem and helping to get these people the care that they require so we can improve their quality of life and their life expectancy. Thank you for joining me this afternoon.
Thank you, Dr. Barkley. It is a pleasure to have you here, and a pleasure also to have our attendees here today. I'm opening our question and answer. We're only going to do just a couple questions, so I'll let our attendees have a moment to put their questions in. But like I said, we're only going to do a couple since we're not going to get to most of the questions today. If you would like to submit questions to our health information specialists so that we can send on references and other information, you can email us at asktheexpert@chad.org. And again, you can email us at asktheexpert@chad.org. And Doctor, if you could suggest one thing, and I know it's much more than one thing, but one thing that an individual could do to lower their risks that you've discussed, what would you suggest that they do?
Treat their ADHD far and away. Get treatment. That includes a combination of treatments, medication among them, of course, but there are 5 things we need to do to address this major background factor that is contributing to all these specific health and wellness problems that's shortening life expectancy. Treat the ADHD. Those 5 things are: get an appropriate diagnosis and thorough evaluation. Educate yourself or the family about the nature of ADHD and appropriate evidence-based treatments. Number 3, go on medication. 70 to 80% of children and adults will need medication as part of this combination of therapies. Number 4, try behavior modification programs. For families, that's behavioral parent training. For teens, that's family therapy, concentrating on conflict reduction and problem-solving skills. For adults, that may be cognitive behavioral therapy, and so on. Finally, accommodations. Work to change the environment around the individual so that we reduce the likelihood that they are impaired by their ADHD. This, of course, includes such things as special educational services, educational accommodations, changes in the home and workplace environments of adults with ADHD so that they can succeed, using ADHD, adult ADHD coaching, and so on. There's a variety of accommodations, but I repeat, the 5 components we need to concentrate on are evaluation, education, medication, modification, and accommodation. Let's start with those, and then let's broaden our interventions to begin targeting these specific domains of health and wellness: smoking, exercise, alcohol use, sleep, nutrition, weight, and so on. But first, we have to address the ADHD and then broaden the intervention to target these other domains.
Thank you, Doctor. And our second question, as I said, we've gone long today, so this will be our second question before we wrap up. Is a question from Liz, and I think it's very helpful. She wants to know how can the greater community make this information understandable for others who have ADHD who may not be present today, but what is a simple takeaway, something that they could offer friends and family who are dealing with ADHD?
Well, first of all, the articles, publications are out there, but they're rather technical. Second, I understand that Chad is going to make this webinar available, that it has been recorded, I hope, so that people would be able to access this particular lecture online through the CHAD and the Help for ADHD.org website. Third, I have posted a blog at the website for APSARD. That's A, P as in Paul, S as in Sam, ARD as in David, apsard.org. We've just posted a blog over there that summarizes this study and its implications for those with ADHD, so you can access it over there as well. And as I understand it, there's going to be more exposure through YouTube and elsewhere because some of my lectures have been recorded and will eventually be posted over there. But I think initially coming back to CHAD and helpforadhd.org and the National Resource Center are probably the best places to begin.
Thank you. Yes, we are recording today, and it will be posted. So I'd like to wrap us up today. Thank you again, Doctor, for being with us. And thank you to our attendees for joining us today. A quick 5-question survey. Pardon me, I also need a drink of water. Our quick 5-question survey will be on your screen shortly. Please take a minute to share your feedback with us. We do value your input and your suggestions, and we do use them to choose topics for future webinars.
Thank you, Robin.
Dr. Barkley, thank you again for joining us today. Everyone, thank you for being with us. This has been an honor and a pleasure.
Be well.